Good morning, everybody. I have been invited by Cerenovus to be the moderator of this session, and that is going to be with Dr. Marc RIBO. Marc, could you come to the close? Yes. So we're going to show cases and show the advantage of disadvantage of all the different tools. I think our practice has changed. In Houston, we're doing most of the time everyday cases with stroke, elbow, large vessel occlusion, and we have a lot of tools, a lot of excellent tools. All the industry have excellent materials, and I think the best material is the one that you are familiar with. You know, I'm here just to show what is my everyday practice, and this is the different devices that Cerenovus is offered to us. The Cere-based distal access sheath is the one that I use the most in the 95 for stroke. We have also the large bore catheter, is the name of that in US. Here in Europe, it's called EmboBac. We don't have the Prowler Select Plus, that is a 160 centimeter microcatheter. Normally, I use the Headway 21, 163, I think, and the EmboTrap 3, that is have multiple compartments inside and has been very effective. So what is our preferred approach? It depends. I think that depending if the patient is presented with a tandem occlusion and the carotid artery is occluded at the level of the neck, that's the few cases that I like to use the balloon. Normally, I don't use a balloon guiding catheter with the balloon, but if the patient has an occlusion of the internal carotid at the level of the cervical region, this is one of the cases that I use. This is the aspiration plus stent retriever. I used to call Solumbra a long time ago. Now, so we have the advantage of the aspiration, that is this one, and the closed retriever. So this is the normally I use. I like to use most of the time, of course, depend on the case. If this is a tandem occlusion, if the patient have enough cross-filling of the ACOM or PCOM according to the hemodynamic. But my primary technique is to use the combination of closed retriever and aspiration at the same time. So this is the conflict of interest. And I want to show you a case that I did Friday that I was on call before I came here to Paris Sunday. This is a patient, 63-year-old, and we have the mobile stroke unit in Houston from the University of Texas. And the patient was picked up with a right-sided weakness and aphasia. And they had the capability also, they have a CT scan inside of the ambulance. So they can do the CT scan there and they can do the CT angio. So when they do that, they call us and we're ready for the patient. Most of the time, the patient is coming directly from the ambulance to the angio room. So the patient, the onset of symptoms was at 2 p.m. and the patient was receiving TPA on the ambulance. So it's already buying time. So get into the Houston Methodist Hospital at 1521 and was activated. I was on call. They called us. We are ready for that. And the CT angio was confirming the occlusion of the left A1 segment. When they tried to obtain an intravenous access, because there was a loss of the vein, the symptoms resolved completely. So the patient, basically the NIH was an occlusion of the A1 segment, but the patient was given TPA and the patient was getting better. So they canceled the elbow team. They said it's not necessary to do anything, the patient is better. But then at 7:40, that I was ready to go home, as usual, they called me and the patient is getting worse again. So this is a good, case just to discuss later in this meeting, all the endo-low and extreme mostly trial that is coming to treat patients with a low NIH. But this is not the purpose of this case. This is the quality of the CT that is performing the mobile unit. And this is when the patient gets to the Methodist. We repeated the CT because the patient was getting better. And there is a hyperdense left M1 segment, as you can see here. And the CT angio confirmed the occlusion, and we can measure the length of the clot. So this is the first injection at 6:14 that day. So we injected, we see occlusion of the M1 segment with a good collateral circulation. That's the reason the patient was getting better, and then maybe there was exhausted collateral circulation that most of the time happened. So at 620, we have the microcatheter distal to the stenosis, and let me show you that this is the Cerenovus 95 that has a very soft tip, and we can go very distal, as you can see later, into the petrous or cavernous ICA. So I don't use an H-frame sheath to go, because the transition to the stylet and the catheter itself is very smooth, so we don't have to put an H-French, so we can close this with an Angio-Seal 6 French instead of 8 French. This is the large bore catheter or embovac, and this is aspirating from the embovac, but at the same time I have the embotrap 3 intracranially. So when we're doing the aspiration, at the same time I'm using this lock syringe that I'm aspirating from the Cerenovus. So it's doing the function of having a balloon, so by decreasing the risk of dissecting the internal carotid with the balloon. So very unusual, I'm using the balloon in our practice. So here you can see this video with the injection of the internal carotid, showing the collateral circulation that is, consistent with the patient improvement. And then the embovac is going into the facing I put the embotrap first, and then I advance the embovac after that, but the clue is to have like a 10% of the clot retriever inside of the embovac, and look at how the Cerenovus is going into the petrous carotid, and at the same time I'm aspirating. So I have a dual aspiration, and this is, I show you so this is again, so this is the Cerenovus in the petrous carotid, in the cavernous carotid. This is the embovac, and this is the embotrap 3. So this is a 627, basically 13 minutes. So I think that's what we want. Recanalization definitely is the best that we can do for this patient, and ideally we need to go for a one-pass TK3 or TK2C. That's our goal. So this is the diffusion 24 hours, immediately the aphasia disappeared, and the patient did clinically perfect. Still is in the hospital when I came back yesterday. So this is, I modified the penumbra technique that was described a long time ago, that the only thing that I do is just to put, I have to put the intermediate catheter or the aspiration catheter in front of the clot, but also the clot retriever, in this case the embotrap, is partially inside. So I don't do it, it's partially inside. It's basically to get the clot from both sides and doing this to the clot. At the same time, we advance the Cerenovus into the petrous or cavernous because it's very flexible, and do an aspiration from that. So this is another example. We have the Cerenovus here. We have the intermediate catheter, aspiration catheter, and the embotrap is deployed crossing the clot, but the clot is exactly here where my arrow is. So basically I'm trapping the clot between the tip of the aspiration catheter, the embotrap that is partially in, and also the embotrap that is distal. And it's very effective to get just in approximately 92% we're getting TK3 or TK2C in one pass. So this is a normal case. This is a regular case that we did, as I mentioned before I came. And I think there are a lot of advantages for the Cerenovus, the flexibility, the stability, the capability to put the catheter, the distal tip of the catheter into the petrous or cavernous ICA and do an aspiration is very advantageous for this type of procedures. Now I would like to present Dr. Marc RIBO, that is going to mention his experience and doing a large vessel occlusion treatment.
But Orlando, just a question here. You showed a nice case with a very low NIH, 0 or 1, and my question would be, when you're about to start such a case, do you change something in your mind or in your setting? Are you considering using a different approach because the NIH is low, or myself, what I try to keep in mind is that I would not be so aggressive in these cases and try only one pass or two passes and not.
It's a good point because most of the cases that we do, the NIH is very high. So we mentally, emotionally, we know that very unusual. We have a complication. We can have perforation, etc., vasospasm, dissection, but we're helping the patient. In this particular case, that the patient is the NIH is low, is more challenging because you need to have a technique that you feel comfortable doing it, and it's going to be more effective. Most of the time, I don't change for M1 segment for the basilar. I'm using this combination, the embo trap with the Cerenovus, and I can change the aspiration catheter. Sometimes the embo back is stuck into the ophthalmic artery and it's difficult to go distal. But I think this combination, especially at double aspiration, is going to be good. So of course, we need to be careful because the patient have a low NIH, so we need to, but being aphasic is going to be terrible for this patient that is going to develop. This patient is going to have a massive stroke if we don't do anything because occlusion completely of the M1 segment.
And while we're changing, I was surprised to see that in mobile stroke units, you're not doing CTA.
Say that again?
The CTA in the mobile stroke unit, so when the patient comes in, you still need to repeat imaging. Is it not possible to perform vascular imaging, the CTA on the mobile stroke unit that you're using?
They can do it. They can do the CTA engine, the mobile unit, and sometimes they bring the patient with a CTA just with a hyperdense M1 segment, and we can do a DIAZ CT, and it's going directly to the angio. So we're buying time.
Okay, so let me just...
So, show us your approach.
Switch. Okay, so yeah, the idea of the session here is to explain, share with you our approaches, and we all faced cases like the one I'm showing with this extreme tortuosity, and obviously we can still get effective results, but we would agree that it's not the ideal situation. You completely lack of support, and you are basically trying to scratch the clot. And in this case, we were fortunate to get it out. But in general, I am aiming for an optimal support. And when I see this kind of tortuosities, I try as much as possible to overcome them and to strengthen the carotid. And for this, I think first we need a good guiding catheter or sheath that would be atraumatic with a soft tip. That because you still need to go through all these tortuosities, so this is important, and to have this kind of feature at the tip. And not only the very end of the tip, but we're getting to this kind of hybrid guiding catheters, in which the last centimeters, they are really very flexible, and they are comparable to the distal access catheter, aspiration catheters that we are using. So really, this is a kind of hybrid catheter. And I wonder if at any point we will be just switching from two catheters to a single hybrid one that will allow us to consistently get with your sheath intracranially. As you can see here, the flexibility of the distal tip allows us to get what Orlando showed and what I'm going to show you later in my case. And the advantages of this. Obviously, the first advantage is that when you're dragging the clot down, you can always have the rolling effect of the clot through the stent retriever, and you progressively lose it until the point where somewhere in the siphon, because the diameter of the artery gets wider, you can just lose some fragments.
Mark, so, I'm sorry to interrupt. Do you aspirate through the Cerenovus when you are doing this, or you are doing dual aspiration when you are bringing the embo trap?
So the concept of the dual aspiration makes sense when you have a room between your guiding catheter and your aspiration catheter, and this is not always the case. I'm going to show that with some combination, this is possible. You can get an effective aspiration through your guiding catheter. So the idea is to have it as close as possible to the clot, to advance your guiding catheter. Usually, when I'm anchored with my stent retriever, before I start pulling, I get the best support and I advance the cerebase as up as possible. And I only pull my distal access catheter, and this is to avoid shaving. When now you see my guiding catheter is very high, and I pull only when the distal access catheter is facing, as you showed, the clot and the stent retriever, when there's no angle, to avoid this shaving and losing some fragments. And of course, if you have stent retrievers with a kind of filtering cells at the distal tip, like an embotrap, it eventually will avoid to lose these fragments also. So another thing we need to keep in mind always is to maximize the aspiration diameter as much as possible. We have to keep in mind that clots we will have to drag them through a tube that is increasing its diameter, and to avoid the embolisms to the ACA, for example, I always try to maximize as much as possible the size or the bore of my aspirating catheter. I think the distal access catheter has first this mission, and the second is to give you the support you need when, or to readdress the forces when you are pulling through curves in distal occlusions. So you don't want to have this kind of avulsion damage that you can cause when you are pulling without support. And if you have support, you see that it nicely corrects the forces, and you don't have you are not tearing the artery. So not only this, but while we are pulling and we might be aspirating, but coming back to your question, right? At some point, you're going to have your clot here occluding with your aspiration catheter, and all the so there's not going to be any more flow reversal or aspiration at this point, and it would be very useful if you still have some reversal of flow and you have room from between both your catheters at this level.
Yeah, and one of the advantages of the Cerenovus sheath is that the inner lumen is 0.090, so a little bit bigger than the other long sheath, so there is a little bit more capacity for aspiration.
Exactly, and also the large bore catheter, or the Embovac for the 071 catheter has the smaller OD, so it allows to have an additional room here for aspiration between both of your catheters. So you can apply the dual aspiration that you were commenting in your case, as I'm showing here. So of course we have the whole set of tools to achieve great results. However, we all face cases like the one that I'm going to show here that are tough. We just presented cases with excellent outcome, but this patient, well, basically it's a typical M1 occlusion with a high NIH score, but at this point we performed a first pass with aspiration only, and then our second option was to add a stent retriever. We got partial recanalization, but if you look closer here, there is a filling defect at the bifurcation, and at this point we thought that the better option was to add a second stent retriever. You can see that the clot here is progressively growing, and when you enter in this kind of cycles, yeah, you feel like you are just not going to end well, despite several passes that we did with several options. We never got rid of the partial clot that was still there, and we felt that maybe we need some kind of better tool. A dedicated stent retriever for those fibrin-rich clots, hard clots that are not responding well to the first line stent retriever. So we're going to talk about this specially designed stent retriever, the Nimbus, but I'm going to place you to come back and to hear us in the next symposium on Thursday. We're going to explain the features of this specially designed stent retriever. So any other comment, Orlando, or somebody from the audience?
Any questions or any comments or any? Do you have here in Paris the mobile unit, the stroke? Jackson.
So I heard Dr. Grota's presentation. It's becoming how many of your patients are coming through a mobile stroke?
Not a lot. I think that we can have one every 2 weeks because we have 4 hospitals in Houston covering. But it's not frequent. This is very unusual, but we are prepared. The advantage is that it's coming from the unit directly to the angio room without going through the emergency room. So I think that the Cerenovus have several tools that I can improve or resolve, because definitely recanalization is the best that we can offer to this type of patients, and has been demonstrated that decrease the disability of the patient. And I think every time all the industries and all the companies are producing new material that make our life easier and we can have a better result. Maybe in the future we don't need a mechanical thrombectomy, and maybe we're going to be using medication intratracheal and dissolve the clot very efficiently. But nowadays, I think that our purpose is to have TK3 one pass. I think that that's what we want every time, but we're getting this more and more frequently, trying just to do one pass and get a TK3 or TK2C after one pass specifically. So if you have any question, we're ready to answer. Yes?
This is Muhammad Al-Mahdi from Egypt and Saudi Arabia, working in a group of hospital having stroke network. Actually, I'm asking about this picture specifically. If you encounter this picture for wake-up stroke, you see it is intermingled between the gray, which is a normal tissue, and the white, which is infarct tissue. So it's not completely white, but it draws the MCA territory. Would you go for thrombectomy for such a case?
Yeah, well, good question. I think, that was obviously the follow-up after all we tried, but if a patient comes in, especially if he's young, here there might be also some kind of hemorrhage or blood extravasation, but with this kind of lesion in a very young patient, I think it's still today makes sense to try. Maybe we can spare some of the tissue here, more in the posterior areas, or maybe higher. There might be still some penumbra to save. So if a patient comes in with this, obviously it's looking bad, but we might try to offer him a chance before hemicraniectomy, obviously.
Mark, this is after you try so many passes. This is after the patient is stroke out. It's not the initial MRI that the patient presented with.
No. This is immediately after, when outcome is bad. We perform an early MRI to try to understand if the patient will benefit from a hemicraniectomy.
Yeah, this is exactly what I see because I receive patients with this MRI initial imaging. And then I operated on those patients and they performed well later, especially in young age. But this is not, this will give us a miscalculation that it is very big, it is total MCA territory, and then there are some people who will not operate on those patients.
I make a comment, Mark. I think, I just seeing one slice here, I'm surprised this patient actually progressed to brain death, right? So first thing is this is not a baseline MRI. Be very careful with baseline MRI because this pattern can be reversible. You have more than 10 cc's of DWI reversibility within the first 6 hours in 15% of the cases at least. Secondly, there is the size of the infarct and the quality of the infarct. And that's not something we think about. We just look at size. But if you look at this is not pan-necrosis where you have like that wedge that is all white, right? What you have there, it's mostly selective neuronal loss, right? It's just the cortical ribbon that it's affected. And the final thing is we're always thinking about neurons as opposed to the neurovascular unit. What you have here is neuronal loss because that's the high metabolic demand area. But the blood-brain barrier is actually composed by vascular cells, right? Astrocytes, glia. And those cells are not dead. And by reperfusing that territory, you may actually keep the integrity of the blood-brain barrier breakdown and decrease the amount of swelling. So there is some emerging data suggesting that if you actually intervene relatively large infarcts, you may decrease swelling up to a certain size. Obviously, when you get to the mega infarcts, then even the neurovascular unit, glia and endothelial cells, they are gone, and now you're going to have a problem. But there is something, again, an infarct is not an infarct. There are shades of gray. So there is a point that even a large infarct will benefit from aggressive reperfusion. Okay? And remember, even the DWI, it's not always core. So I think patients deserve the benefit of the doubt. The question here is not that the patient had a bad outcome, right? But if you treat 100 of these patients versus not treating them, what would be the best for those 100 patients? Obviously, it's a bad situation, right? You're not going to have a good outcome, but can you have a better outcome than if you don't treat?
I completely agree. I think there is a lot of things that we need to learn about. At the beginning, we thought that everything that was in diffusion means that the brain death, but we're learning that it's not like that. So there is room for having more patients and benefit for mechanical thrombectomy.
Agree. Yeah, this is not the baseline. Again, remember, this is after we did everything was in our hands possible to recanalize.
Okay.
Thank you very much.
Good. Thank you very much to both of you.